Respected chairpersons, my dear teachers, senior colleagues, and friends, I thank Dr. Kiran and Dr. Manikandan especially, and the organizers of this team or this conference for the opportunity given to me. So, this case is a case of a patient with ischemia as well as bleeding risk. How to manage such a case? So the case given to me is a 76-year-old female who has presented with NSTEMI. NSTEMI diagnosed by dynamic ST changes and troponin elevation. The echocardiogram showed wall motion abnormality and adequate LV function. She also has got diabetes mellitus. Her EGFR is 38 ml per minute. BP is okay. Heart rate is reasonably okay. But she had melena 5 days ago. Hemoglobin is 9.1. At present, she does not have ongoing bleeding. I have to say that Kiran has given me a tough case because there are lots of problems here. So what are the decisions to be made? One is the initial management. What is the ischemia initial management, including the risk stratification, including the decision on PCI and pre-PCI management. And what about the GA management also? She had melena. If deciding on PCI, what are the considerations during PCI? And after PCI or during medical management, what will be the short-term and long-term management? These will be the considerations. So first we will risk stratify this patient. There are several risk stratification tools, like a Gray score, which is shown on the left side, or TIMI score, which is available in the net also. I have calculated the Gray score here, and it is 150. And Gray score of more than 140 is a high risk. So, this is ACC-AHA recommendation of NSTEMI management. They have classified patients with NSTEMI into very high-risk patients who are unstable in cardiogenic shock. So, very hemodynamically unstable, where they should have urgent angioplasty to save life within 2 hours. Whereas high risk, where Gray score is more than 140 or dynamic ST changes, this group our patient belongs to because she had dynamic ST change and Gray score of more than 140. As a class 2A recommendation, a coronary angiography is recommended within 24 hours for ischemia management. That is about ischemia management. So our patient, from her ischemic point of view, needs an angiogram within 24 hours. She is a high risk person. And if you do an angiogram, forget this part, if in an angiogram, if there is a lesion, it may be amenable to PCA, you may go for PCA, or it may go for bypass graft if it is a multivessel disease not amenable for PCA, or sometimes we may go for medical therapy also. So after angiogram, we can go in different directions. So that is the initial ischemia management plan. And along this ischemia management plan, we have to understand that all ischemia management is with aggressive antithrombotic therapy, with heparin or other anticoagulants and dual antiplatelet therapy, which can be detrimental in our group of patients. And in NSTEMI, if you are planning an angiogram within 24 hours, the recommendation is that we start only aspirin. Don't start dual antiplatelet therapy, because after doing angiogram, if the patient has to go for a CABG, then it may be difficult because to stop the DAPT, the other drug. So as a recommendation, if it is angiogram is planned beyond 24 hours, we may start dual antiplatelet therapy. Which dual antiplatelet therapy, ticagrelor, prasugrel or clopidogrel are mentioned, but in our specific situation, I will consider clopidogrel. I will come to that later. So this is the clinical snapshot. A patient has got high ischemic reasons, age, comorbidities, NSTEMI with dynamic change, echocardiogram or wall motion abnormality. At the same time, the big arrows from the right side, patient has got a hemoglobin less, a EGFR is low, and patient has got had melena. So this is a high bleeding risk. For high bleeding risk, there are other risk scores, just like ischemic score. One is the ARC bar criteria. I will just brush through it. There are major criteria, 14 numbers, and minor criteria, 6 numbers. And if there is one major or 2 minor, that patient is high risk. So that is a complicated slide. Just look at this. This patient has got major criteria, recent bleeding. Anemia, major criteria. Age, minor criteria. and moderate CKD. Mind you, less than 30 is major criteria. Here it is just 38. The next moment without treatment, the creatinine renal function may worsen. So the verdict is this patient is with high risk of bleeding. And there are other bleeding parameter, precise HBR score also, which also tells that in our patient, I calculated the score and tells that the score is very high. And this patient has got 43 points. Any point more than 27 is very high risk. And as you can see that 47 is in this level of the graph, the bleeding is high. So our patient has got high bleeding. So if the patient, if with your treatment there is a bleeding, it can be fatal. There can be significant myocardial ischemia, prothrombotic state, and the patient's hypertension can develop and patient's renal failure can worsen. So it can result in mortality also. So we don't want that. What to do? So we can see that in high risk NSTEMI, it is only a class 2A indication. And the ACC 2025 guideline says that it is a relative contraindication, that is high bleeding risk is a relative contraindication for routine invasive approach in ACS. So should we do or should we not do? So one side, the patient is high risk of ischemia, and the other side, there is high risk of bleeding. So Gray score is high, dynamic ST change, RWMA. The patient has come from a from some other place, wanting coronary angiogram, and the patient is pressing for angiogram. Okay, we have to tell the patient that both sides, that angiogram has got a risk and invasive management has got a risk. But if you don't do invasive management, what will be your antiplatelet strategy? Still you have to give antiplatelets, still you have to give antithrombotic therapy. So I think that we cannot passively manage the heart. Intervention is required, but the precision in the man is mandatory to avoid hemorrhage. So you go ahead with angiogram and angioplasty, but with a precision management. So what is the precision management? Do you do a cardiology priority approach or gastrointestinal priority approach? Because this patient had GI bleed. Do you want to address that? Okay, some authorities feel that in a patient who is now hemodynamically stable, you do an endoscopy and find out the lesion and tackle that so that the patient does not develop significant bleeding and develop fatal complications. But sometimes it may not be easy in an acute MI patient to get a gastroscopy and the procedure. So probably we may go for a medical optimization. Initial part we give high dose of PPA. If the patient has got bleeding, active bleeding, only aspirin is indicated. If the patient should hold P2Y12 inhibitor. If the patient does not have active bleeding, we can give dual antiplatelet therapy. The second part is the patient's hemoglobin. If the patient has got a hemoglobin of 9.1, anemia can precipitate myocardial infarction. This is class 2 MI. Is this patient's myocardial infarction because of anemia? Should you give blood transfusion? Previously, there was a restrictive threshold. Less than 7 only you used to give blood transfusion. Now, as a class 2A recommendation, it is given here. ACC/AHA 2025 says that you may give blood transfusion if the hemoglobin is less than 10. And it is supported by one trial, mean trial. And so now the recommendation is probably to give a liberal threshold of transfusion to target hemoglobin to more than 10. So we have decided, we have given blood transfusion, we have started aspirin, clopidogrel, and the procedure strategy to minimize bleed, we go for a radial approach, and if femoral approach is used, you do in a careful ultrasound guided manner. Don't forget the kidneys. This patient has got a low GFR. So when you give contrast, the patient can go into renal failure. So you go for ultra low contrast PCI, which can be done by IVAS guidance and also for hydration. And during the procedure, one method which can probably reduce the duration of antiplatelet future is a drug-coated balloon. What is drug-coated balloon? Usually we use a drug-eluting stent where the drug is there in the stent and the stent remains back. Whereas in drug-coated balloon, nothing remains back. The drug is coated over the balloon. Once you apply the balloon, the drug is there and you take out the balloon, there is nothing remaining back. The advantage is that probably you can stop antiplatelets, dual antiplatelets after one month of therapy. And so this is the workflow, and you do the lesion preparation, assess, and drug-coated balloon is prepared. If there is inadequate result, you can probably do a bailout stenting. Drug-coated balloons are used for other indications also. Our patient may have these indications: high bleeding risk. This patient is a diabetic, can have small vessels, and may be having bifurcation lesions. These are other indications for drug-coated balloon. And regarding anticoagulation, bivalirudin and heparin, some authorities prefer bivalirudin, but my experience is bivalirudin is less. We commonly use heparin. What about long-term management? In the acute phase, dual antiplatelet therapy, if there is no active bleeding, is continued for 1 month because this patient has got high bleeding risk. Aspirin plus clopidogrel. The potent drugs like ticagrelor and prasugrel may be avoided in this situation because of the high bleeding risk. And aspirin free treatment is not recommended because studies have shown no benefit or harm. After the acute phase, if there is this I have already discussed, if there is active bleeding, you may give only aspirin and no P2Y12 inhibitor. After the acute phase, concentrate on the last part. After the first month, dual antiplatelet is given for the first month, and after the first month, single antiplatelet is recommended. And this after first month, I will recommend clopidogrel monotherapy to aspirin alone. And so, to sum up, we have to risk stratify, consider ischemia and bleeding, discuss with the relatives, resuscitate, you may give blood transfusion, investigate, you may do endoscopy. If you cannot do endoscopy before the procedure, even after the procedure, in the first few days, do endoscopy, find out the lesion and treat it so that the patient will not develop bleeding. Intervene, radial access, ultra-low contrast method, and drug-coated balloon instead of drug-eluting stents. And medications, a short DAPT, that is 1 month dual antiplatelet therapy, followed by single antiplatelet therapy of clopidogrel is preferred. Thank you for your kind attention.
Managing perioperative bleeding. Post-procedure in a patient with MI, managing the risk of ischemia and managing the risk of bleeding is very important considering the post-operative and post-procedure morbidity and mortality. Sir has mentioned all the valid points, how to evaluate a patient, how to investigate a patient, how to manage the patient, and what are the points which has to be considered while taking up a patient for an angiogram, and how to manage the patient post-procedurally. And the topic is open for discussion.
So it's a question of what you are seeing right now, what is the presentation and what is the anticipated issue. What you are seeing right now, the seen thing is ischemia, and the unseen anticipated thing is bleeding. So you have to treat the patient's presenting problem, no doubt about it. But at the same time, the safety has to be considered, isn't it?
Yes, there are several case reports. We went through that because from the gastroenterologist point of view, when I searched the literature, there are several cases where they have done endoscopy and clipped. If it may be just a big bleeding which is about to happen, just clotted, and you give antiplatelets, heparin and all those things, patient bleed. So if the patient is hemodynamically stable, why don't you do endoscopy and do the treatment?
Absolutely.
So that is, or if you cannot do it immediately, after the procedure itself, you can do on the next day. Don't wait for too long to treat it.
So in the fear of a bleed, don't put the patient in trouble. I think for a gastrointestinal issue, gastrointestinal and upper GI endoscopy is a bedside procedure which can be done in the CC itself. They can do it, if needed they can clip it, if needed, if the varices can be treated. So that's not an issue at all.
So this should be an aggressive approach. You should not deny revascularization by PCA. We should do that, but only thing is that we should take adequate care and management of the other issues.
Anticipation and all what all problems can occur, that should be covered. All the contingencies should be covered.
Should be covered.
And second thing is angiogram should not be denied because we want to know what is a life-threatening problem, ischemic problem. If it's a small vessel disease, it's a diagonal disease, it's a distal vessel disease, we can leave it alone for medical therapy, or as you suggested, a selective cases can be taken up for a drug-coated balloon treatment. But if it's a critical left main disease, we do not know until and unless we do an angiogram. An angiogram is unlikely to harm the patient much.
And actually, the studies have shown that only 50% of the acute occlusion shows STEMI. Around 50% present with NSTEMI, total occlusion of the vessel. And NSTEMI is 30% have totally occluded vessel. So we are missing lot of totally occluded vessel. We are losing time. This patient had a RWMA of the anterior wall territory, interventricular septum. Probably the patient is having a critical lesion in the proximal vessel. This is an indicator for early invasive management.
That's why I think the new classification is coming up, occluded MI and non-occluded MI rather than NSTEMI or STEMI. So it's a perfect balancing act. And if you go for an intervention, it should be a precision. It's a precision PCI.
Precision
using an imaging, because the STOP-DAP trial 100% imaging. It was 100% imaging. Only one more thing is, if you are using clopidogrel for a long-term therapy and 30% prevalence of clopidogrel resistance, in a critical situation, you are going to put a left main stent or a complex bifurcation stenting or a CTO stenting or a single surviving SL. Would you like to do a genetic testing and continue with the clopidogrel?
So it has not shown any significant benefit in the practical scenario. And actually, there are a lot of variations based on the race also. The Eastern population, they have said that the clopidogrel is much better and the bleeding is more. And that is from Korea and Japan. And they prefer clopidogrel in high bleeding risk because they have got data. Do we have data on that? That is a problem.
And except the STOP-DAP trial, all the other trials have used single antiplatelet therapy with the ticagrelor.
STOP-DAP 3 trial you are mentioning.
STOP-DAP 3.
3. That is prasugrel. Prasugrel.
We don't have clopidogrel as a single antiplatelet therapy. We don't have a data on it.
No, we have. We have data.
Post PCI.
We have data.
Only one trial.
Yes,
Majority are ticagrelor based trials. Majority are ticagrelor.
Clopidogrel, there is data. The reason I just tell, HOPE exam or something like that.
That is there. That is clopidogrel following. It's
6 months of treatment.
Yeah, it's all long term after the.
But
PCI.
these patients, all these patients with high bleeding risk were excluded in these trials.
Absolutely.
So can you extrapolate this to high bleeding risk? Will they develop bleeding? So they all CKD patients were excluded. High bleeding risk patients were probably excluded. So how can we extrapolate that to this?
This is not based on a data. It's a it's a clinician's judicious decision making.
That is a problem. If the patient develops a bleeding, that can kill. I think probably years back when Rajesh came here for a meeting in the gut club, he said that the gastroenterologists tell that we see the bleeding caused by you and you don't see the bleeding. So we underestimate the bleeding produced by us. So we have to be very careful. I fully agree
with you that, because we underestimate the bleeding, because bleeding patients do not come back to us.
So that we think that it is a less of a problem, but it is not. We have to be very careful.
It's an extremely tough balancing act, but we have to manage both. We have to manage the ischemia, we have to manage the bleeding, so we have to take a middle path. Thank you. Excellent talk.
Thank you so much.